novel investigational therapies for patients with refractory disease. Dr. Yanik has presented here at our conferences many times, and we're very happy to have him back. It's been a little while. And I would cite the 65 or 70 pages of articles that he's written, but I just can't do it. I really appreciate him coming back, and he will be talking about MIBG.
You know, it really is a pleasure to be here. As Pat said, I'm Greg Yanik from the University of Michigan. And I don't even think I'm going to talk about my talk. I may just talk about the questions that were just asked after Ami's talk. Those are some of the most in-depth and sincere questions that I've heard at any talk ever. Ami, you did a good job fielding them. And in fact, I was thinking about some of the questions that were asked, and you know, from my opinion, I'll just give you a few answers from my opinion on some of them. And they were just beautiful questions. I don't find that the rates of neuroblastoma are increasing. I find that the rates of detection are increasing. Patients are also living a lot longer. When I started my fellowship, the 3 to 5 year survival was only around 20%. You know, now we're up for, this is for patients with metastatic or stage 4M disease. Now we're up in that 60 to 70% range. So our detection is improving and our therapy is improving. The average pediatrician will see 0 cases of neuroblastoma during their career. That's quite a staggering thing. 0 cases. We did a study at we did a quality control study at our center to look to see what was the length of time from the initial onset of symptoms to the diagnosis being made. What do you guys think it was? A year? That's a good year. A month? About 4 months. So the average child was taking about 4 months to make a diagnosis. And oftentimes it's because, you know, they'd have, let's say the typical child, I'm sure Kate and Daniel and Ami and Brian Kushner, some of my colleagues from around the country, would agree that the average pediatrician starts focusing on the hips with x-rays, or on the feet with x-rays or something. They're missing it totally. And then eventually it becomes obvious. I love the question from the gentleman, where is he? His child was in Mexico. There we go. What's your first name? Avalto. You know, it was a great question because we're never sure the answer ourselves in terms of, is it just persistent disease or is it relapsed because of this? And I wasn't going to show it during my talk on MIBG therapy, but the definition of remission really means what can we detect with the limits of the scans that we have. And Kate's seen it with MIBG therapy. We'll say we'll take a child into our MIBG therapy, we do a scan before, and the child may have, let's just say, 2 sites of disease. Then after MIBG therapy, we're giving a dose that's, you know, 200 roughly times what a scan dose is. We rescan the child immediately. And we prep our patients and our families that we may see a lot more. So now we do a scan and maybe they'll have 4, 5, 6 sites of disease. Did that mean that they picked up 3 or 4 more sites by going through MIBG therapy? No, we just gave them a bigger MIBG dose. Our detection sensitivity improved. And thus, you know, is it a relapse? Is it just refractory disease? In many ways, it depends on the limits of sensitivity of the methods using to detect it, okay? With that said, I also want to speak, I'm sure I can speak for all the physicians here. We have the best job in the world. We really do. Being able to take care of the thing that you value most, and that's the lives of your children. I'm honored to actually be here speaking to you, but I'm actually really honored to be able to help to take care of your children every day. So with that, we'll start. By the way, this is one of my patients, a young man. MIBG therapy does not do this to you, but it is amazing what you can do with those little otoscope speculum ends. And if you ever wonder why healthcare expenses are going up, maybe it's because oh God, I loved it. So I have no disclosures or conflicts of interest. This is just an outline of my talk. What is MIBG? How does it work? Ami talked a little bit about it, but when is it used to treat neuroblastoma? As she mentioned, Curie scoring. I'll talk about how it's done, what have we learned from it, and some of its implications for all of you and your children going through therapy, okay? I'll actually teach you how to score it today, okay? Let's just start with this. Ami had the name on it. It's actually on the National Spelling Bee. It's meta-iodobenzoguanidine, okay? And so what the bleep does that mean in English? You know, by the way, MIBG is similar to a hormone called norepinephrine. Norepinephrine is a signal. It's a chemical. It's a signal between nerves. Okay, it's a signaling protein. Norepinephrine, like epinephrine, is a form of adrenaline. All right. I'm not going to make you a biologist or biochemist, but you can see on the left-hand side the chemical structure of norepinephrine, and then on the right-hand side you see the chemical structure of MIBG. That little, you can see there's a lot of similarities there. That little red circle is where our radiochemists, it was invented at our center at the University of Michigan. They attached a radioactive iodine particle to one end of this compound, in essence making it look like radioactive adrenaline or radioactive norepinephrine. All right? So that's what it really is. There's no test on this, by the way, guys. If you, I don't know if I have a pointer here. Do I have a pointer? There we go. So this is a tumor cell, a neuroblastoma cell. This is the inner core of it, the nucleus. This is the outer core called the cytoplasm. Neuroblastoma cells actually have channels, and it's right here in brown. These channels typically allow adrenaline or norepinephrine to come in and out of the tumor cell. So what MIBG therapy is we've actually made a compound that looks like norepinephrine, and we put a piggyback on it with this radioactive iodine. That MIBG, it's just shown in yellow, will get taken up through these same channels. The tumor thinks it's taking up norepinephrine. Once it gets into the tumor, then that radioactive iodine is released. It causes damage to the nucleus of the cell and this entire cell per se. This is IV radiation therapy, okay? The beauty of it is, I think I'll show it in another slide, is that it, unlike regular radiation therapy, well, let's say we're radiating my wrist, and we just have to focus, sorry, we have to focus the beam, we have to focus the beam on the wrist, the radiation goes through the skin, through the muscle, through the tissue, hits the bone, and back out the other side. MIBG therapy goes to all sites of disease at once. It can hit the wrist, the knee, the skull, the shoulder. We don't get radiation damage to the other tissues around it. It doesn't go through the skin, through the fat, through the muscle. It's localized right inside that tumor. Okay? We can have a mass right up against the spine, and we're not going to be damaging the spine with our MIBG therapy. Okay? So MIBG basics, in low doses, it's used as a scan. In high doses, it's used to treat patients. It is, as I said, IV radiation therapy. The beauty of it is it targets all sites of disease. Neuroblastoma can get into bones, can get into tissues, adrenal glands, other soft tissues per se. It gets into the bone marrow. MIBG therapy can get into all those sites. That's part of the beauty of it. Unlike standard radiation therapy, it's tumor specific, okay? Common side effects. How many people here have actually been through MIBG, had their children go through MIBG therapy? We've got a handful. That's actually pretty good. Maybe I'll ask you at the end of the talk or on the side where you got it at and how was it and what advice did you give to centers doing MIBG therapy. There's nearly 20 centers now in North America doing MIBG therapy. Common side effects, you know, it's actually really well tolerated. The first week, when you're actually in the radiation protection room, I'd say about a fourth of our children will get some nausea, vomiting for a couple days. About a fourth of them will get, I just call it chipmunk cheeks. They get these jowls. The MIBG will localize into the saliva glands, and you'll get what looks like mumps for a few days. I typically just put warm compresses on it. All of our patients have to have a Foley catheter, so we have to watch for problems with that. Rarely do we see some blood pressure changes where the blood pressure goes up for just a short period. So the first week, first month, you know, as the MIBG passes through the bone marrow, it tends to beat up the cells to get collateral damage of the cells in the marrow, especially if there's a lot of tumor in that marrow, because now that MIBG gets locked into the tumor in the bone marrow and you get collateral damage of some of the blood cells around it. So what we see in the first month is typically blood counts can drop down. And depending on the protocol, we may or may not give stem cells, a boost of stem cells, your child's own stem cells back, just to boost their recovery. And then in the first year, downstream, oftentimes, the radioactive iodine, it's iodine that they put in salt because it'll help to strengthen your thyroid gland. That same radioactive iodine can get into the thyroid gland here and actually damage it. I'd say about 10% of our patients will become hypothyroid as a result of treatment. And as Ami said, they take those drops, that SSKI drops, not for 2 or 3 days, for 6 weeks after therapy. And then we always have to watch for secondary cancers. We've treated about 150 patients at the University of Michigan with MIBG therapies, at least that I've treated. I've seen secondary cancers develop in 2 children. And what does that mean? Like leukemias, bone cancers that occurred downstream after the therapy. So I don't know if my physician colleagues have even seen this slide. It's a picture of the first ever MIBG scan reported in publication, okay? So MIBG was developed in 1979 by Don Wieland. He was a radiochemist at our center. You can see the scan right here. How many people have seen MIBG scans? They're tough to read. They look like a series of dots. I have to admit, I'm not sure what I would even be looking at here. The circle is around the left adrenal gland, the right adrenal gland, left adrenal gland there, right adrenal gland. Good heavens. This was this was the first ever publication of an MIBG scan in the literature when it came out. The first MIBG scan, for neuroblastoma was published by Kate's group. Kate Matthews comes from UCSF, and her center has had a long and storied history of giving MIBG therapy, and Don Hattner at her center was the first one to use it for childhood neuroblastoma. And then the group at University of Tübingen, or Tübingen University in Germany, was the first to use it for treatment in 1987. I think the take-home point for parents as you're watching this is that this is not a new drug. This drug has now been around for roughly 40 years, either as a scan or as therapy. So in one slide, I figure I'll just show you an overview of MIBG therapy, just kind of summarize what's been done. Its focus to date has been to treat patients with relapsed or refractory disease. There's been over 2,000 patients treated at least. As a single agent, where it's just given by itself. I always view this as the landmark study. It was published by Kate Matthew, who's sitting right there at this table. She'll be speaking later this afternoon. And Kate reported 164 patients who were treated with just MIBG by itself. This study actually helped establish our dosing. What dose do we give? We needed to see how much can we give? Can we give a second dose? What side effects do we see? It was this study that laid the groundwork for it, I feel. And you can see it was published in the Journal of Clinical Oncology in 2007. MIBG was incorporated into the bone marrow transplant process. How many folks here have had their children go through a bone marrow transplant? Almost 2/3 of the group here. Think about the fact that in these studies that I've got outlined, 2 by our group at Michigan and 2 by other groups, the MIBG therapy was incorporated directly into the transplant itself as part of the transplant regimen. And you can see some of our reports there. We actually had the toxicity of it. We didn't find it added hardly any toxicity at all to the transplant. It was very well tolerated. Some of our responses were dramatic, but in the end it became logistically difficult to do with transplant. Maybe I'd like to have seen better responses than I actually saw, and we've kind of stopped doing it in this way now. One of my colleagues who trained with Kate, Steve DuBois, is now in Boston, has done a number of studies combining MIBG with different agents. And then he just published a landmark study showing that MIBG actually is taken up better, has better effect when it's given with a drug called vorinostat. Okay? So if you get MIBG therapy now, you're likely to get it with this, quote, radiosensitizer, this drug called vorinostat. It actually makes the MIBG, in essence, stronger. Okay? So we should just stop the talk right now. I should just talk to everybody who's had MIBG therapy, the handful, and just see how your kids handled it. As Ami pointed out in her earlier talk, patients are in a lead-lined room or behind lead-lined shields. Our typical patient, depends on the size of the dose, is in the room anywhere from 2, 3, up to 5 days. The longest I've ever had a patient in the room was 7 days. The larger the child, the larger the dose, the more radiation that has to be cleared. Each center has their own guidelines. So our guidelines at Michigan are different than Cincinnati's, are different than Kate's at San Francisco. They'll be different than the group in Philadelphia. The standards are set by the radiation safety services at each center. In fact, as parents, if you could even ask us, maybe as physicians, guys, can you get your act together and come up with a common set of standards? How we treat patients at U of M is not how, in terms of how conservative we are in terms of allowing the patients in the room, or liberal, varies from center to center. Our center is really strict in the first 24 hours. You know, we're typically the treatments are in an afternoon on a Tuesday or Wednesday. The parents actually can't be in that room for the first several hours after the infusion. They have an ante room, which is a side room, but they can't be in that room for that child. On the second day, we do measurements, and then we tell the parents, all right, you can be in X length of time, and the parents will go in and out, all right? The parents will help with the feeding, the parents will help give medications. We actually use them to partner with the care, as a lot of centers do. At our center, we actually asked, we did a study at one time where we did intake questions and outtake questions of both the patients, the children themselves, and the parents. I was actually struck by some of the responses by this. So here's some of them, some of the outtake. I'm just going to show you examples. So this is parent 1. So this is at the end of therapy, after the child was in the room about 3 days in this lead line room. I'm grateful for therapy, but saddened by the price he had to pay. Here's the exact same child paired with that parent's response. It wasn't that bad. It would have been better if your hospital had corn dogs. Clearly, this child was traumatized by the entire experience. Parent 2, therapy was tough. I had never left her side before, as many of you I'm sure would attest to, during any of her prior therapy. I know how agonizing it was for her. Here's the response from that child, from that parent. It was pretty easy. Plus, I didn't have my mom hanging around me all day. So, I think MIBG therapy has taught me a lot, not as how well it works, it's taught me a lot as a parent. And in many ways, how our children have that ability to handle things. You know, you can learn a lot from a 5-year-old. So MIBG therapy, where has it been used? As Ami pointed out, neuroblastoma therapy comes in cassettes. The first cassettes right now called induction therapy. This is the Children's Oncology Group model. So it's 5 cycles of chemotherapy called induction. The second phase is transplant, 1 or 2 transplants. XRT stands for radiation therapy to sites of disease. That's the second cassette of therapy. If you were to meet with me for a consult, I actually draw all my consults. Cassette 1, induction. Cassette 2, consolidation, transplant and radiation. Then cassette 3 is where you get that antibody, typically with that drug isoretinoin that Ami was talking about. So where's MIBG therapy fallen into this? Well, for the most part, it hasn't. It's fallen outside of this. It's been used for relapsed or refractory disease, and historically this has been its primary role. For probably of, let's say, the 2,000 patients treated, I would venture to guess probably about 1,600 of them all had it as relapse therapy, okay? The Dutch, though, this is pretty avant-garde. Take a look at this picture. There's that same cassette. They did the MIBG therapy up front. Think about when your child was diagnosed. If myself, Greg Yanik, said, all right, the first thing we're going to do is MIBG therapy. We're going to put your child in a lead line room. They actually did this in 2 Dutch studies. And here's what they did. You can see 41 patients. They received as their first therapy MIBG twice. So 2 consecutive MIBG therapy doses. They're split apart by about 6 to 8 weeks. And then those patients that were in CR, complete remission, or had a partial remission, it was 24 patients, they went on to get surgery, no chemo, and then they had transplant. Those that didn't have a complete or partial remission went on to get chemo, induction chemo, and then surgery, and then transplant. This is amazing. And their response rates were actually 71% or 73% in this study. I shake my head at this, how they were able to pull this off. Obviously, they did it in a small country with a uniform healthcare system. They could get things approved. It typically takes me about a good 4 to 6 weeks sometimes to get MIBG therapy approved. We couldn't do this here in North America. We can't wait 4 to 6 weeks to get approval to start therapy. This is the current COG model on the current high-risk study. It's called ANBL 1531. In fact, do you folks ever wonder, I'm going to get off track on this talk a lot. Don't worry about it. You guys ever wonder where these numbers come from? Yeah, you know, Ami gave you a bunch of numbers, and I was looking at her as she was talking, thinking, dang, I should just tell you guys. These numbers are pretty simple in some ways. Yeah, insider trading information here. So ANBL, obviously, the A means an active treatment trial. NBL, neuroblastoma. 1531, 15 means the year it was written, 2015, okay? The 3 means it was a phase 3 trial where typically it's run up against a gold standard. Half the kids will get the investigational arm, the other half will get the standard arm. So that's a phase 3 trial. 1 means it was the first phase 3 trial written in 2015 for neuroblastoma that year. There can always be 2 or 3. And thus, you'll see the next high-risk trial, when it comes down, will have the number 2131. The study was being written in 2021. It was a phase 3 trial, and it was the first of that type. Make sense? Yeah. You know, it's interesting because that's the way I remember it now. I can remember it based on that logic. I'll try not to give away too many trade secrets, though, Daniel. So right now, MIBG therapy is given 3 to 5 weeks after the 3rd cycle of chemo, and stem cell rescue is mandated 2 weeks after the MIBG infusion. At our center, we've often done an MIBG detour. This is for patients who persist with high Curie scores. And what this means is that at the end of 5 cycles of induction, that first cassette, if you have a high Curie score, all those patients are often shunted to get MIBG therapy at our center. And then once we get that score lower, then they come right back. It's just a detour. Then they come right back on track. And then they'll go on to jump back on the track where they get transplant, local radiation, and then their dinutuximab. Well, I guess that leads to the question, A, what's a high Curie score? And B, what the heck even is a Curie score? And thus the rest of the talk, okay? So what is Curie scoring and what have we learned from it? This right here, the 5 individuals across the bottom that you're seeing the picture of, I guess myself included, but this is the group that's really pioneered the Curie scoring that you're about to hear. Kate Mathey, again, I've talked about Kate many times. Love Kate dearly, we're great friends. It was a lot of her work in the 1990s at the Curie Institute in Paris that helped to give rise to how we do this now. So I put a special red around her because in many ways she was, you know, the foundation of what a lot of this was built upon. In fact, Kate, you can just give the rest of the talk. My colleague Barry Shulkin and Meg Parisi, 2 outstanding nuclear medicine physicians. Carrie Strebe from Ohio State. In many ways, Carrie is one of my closest colleagues. You should think about what I'm saying. You've got a physician from the University of Michigan saying that one of their closest colleagues is at Ohio State. And Arlene Nerano, who is just the backbone of our statistical venture. You know, I stole this slide from Shahab Asgharzadeh, who's at Children's Hospital Los Angeles. Shahab used this slide 10 plus years ago. I love this slide. I said, Shahab, I'm going to use this slide whenever I'm talking to folks like parents and some of our trainees. So Shahab always calls neuroblastoma the portrait of a tumor. And how do we look at it as physicians, and how do you look at it as parents and patients? Well, you can paint the portrait in many ways. You can paint it using clinical factors such as age and stage. You can paint it based on biologic factors. You know, Ami mentioned the ALK gene, the NMYC gene. But you can also paint it based on MIBG scans. Think about what I'm about to say here. is that MIBG scans is the only tumor-specific scan that I can think of. If you have lung cancer, you'll get a CAT scan. That's not specific for that lung cancer, it just shows a mass. You may get an MRI for a brain tumor. It's not specific for that brain tumor, it just shows a mass. MIBG scans are specific for neuroblastoma and for a couple other tumors that are in that same category. So Curie scoring is performed from MIBG scans. It was developed at the Curie Institute in the 1990s. The initial studies were led by my good friend Kate Mathey, again in the 1990s and 2000s. And this Curie scoring has now been incorporated into all COG therapy studies for high-risk neuroblastoma over the past 20 years. Ami showed a slightly different slide how it's done, but the body's divided into 10 regions. There's 9 bone regions. You can see they're outlined on the figure there, and 1 soft tissue region. So that means, let's say, the primary mass. If your son or daughter had a mass in the adrenal gland or in their abdomen somewhere or chest. So each region is scored 0 to 3. We add the scores up. So if you do the quick math, the maximum you can have is 3 times 10 or 30. Obviously, if you have a score of 0, that means that you've got no uptake. That's a completely negative scan. We score the bone sites 1, 2, 3 based on the fact is there 1 lesion, 2 lesions, 3, or more than 50% of a segment. And then we score that 10th region called the soft tissue region. You can see the scoring there. 1 is 1 soft tissue lesion, 2 is more than 1 lesion, and 3 is the mass occupies greater than 50% of a region like the belly or the chest. You can just see the numbering, like for example, 5, that's the pelvis. So you got a right side of the pelvis and left side of the pelvis. 8, region 8 is our upper legs, the femurs, and region 9 is our lower extremities. I stole this slide. I steal a lot of slides from folks. I stole this slide from a friend, Matthias Schmidt, in Tübingen. He actually had a great slide on doing the scoring. So this is the patient in red. You can see where the disease is. So that's 1 spot of disease in that right thigh bone or femur. So that's a Curie score of 1. Curie score of 2, in this case, the patient had 2 red spots. The patient who has 3 red spots, though, is still a Curie score of 2. A Curie score of 3 means you've got at least 50% or more of a region being involved, okay? This is how we do the scoring. If I just took some of your scans from your children right now, we could put them up on the screen, and you could probably do the scoring with me, okay? It's not rocket science, okay? So Curie scoring, at least within the Children's Oncology Group, initially we looked at a study, we called it a discovery set, just to see how well it would work within the COG setting. So we used a study called COG A3973. Our nomenclature is a little different then. A, again, was active therapy trial. 97 meant the study was written in 1997, okay? We looked at over 1,500 MIBG scans. We went to Providence, Rhode Island, where the scans are housed. The people that you saw the picture of before, and we scored these scans. We then did a validation set. We looked to see what they were doing in Europe. They have a slightly different trial, different methodology, and a core group of us flew out to Vienna, Austria, and scored their scans. That was our validation set. Again, you got that same cassette, induction, consolidation, immunotherapy. We scored scans at the beginning of diagnosis and right before transplant, so at the end of induction. Here's what we saw. So if you just look at the impact of Curie scores at diagnosis, there's no impact on survival. So in COG A3973, whether you had a score at the time of diagnosis of 25 or 10 or 3, it didn't impact survival. The cut point we used here, a Curie score of 5, greater than 5 I should say, or less than 5. We could have used, Arlene Naranjo did the statistics. She looked at all different cut points, 10, 12, 15. 5 was selected for this slide just because it had the widest disparity in outcome. Well, the outcomes look pretty similar there. These curves, how you read them, by the way, years are across the bottom, and the survival, whether it's overall survival or what we call event-free survival, I'll walk you through that in a second. It would be on the y-axis, and you can see that everybody starts at the top at 100%, and then you can see as you get out, 4 or 5 years survival here for this study. So then we actually looked at the impact of the Curie scores at the end of induction therapy right before transplant. Same study. And now we did see a big difference. We found that the optimal cut point was a Curie score 2 or less versus those that had a Curie score 3 and above, or greater than 2. I think it's pretty sobering that for those patients who had a Curie score greater than 2 going into transplant at the end of induction therapy, you can see their long-term survival here. So it was based on this slide right here that the mantra has been over the last decade plus, you try to get down to a Curie score of 2 or less at the end of induction. Is that really true? I'll walk you through it though, okay? By the way, the next thing we did, I said that we sent a bunch of investigators out to Vienna, Austria to score their scans and see what we get on our methodology on their study. They actually sent investigators from Vienna, Austria to Providence, Rhode Island, because they had their own scoring method. So we actually crisscrossed in the air. The sad part about this whole thing was I had to stay back at Providence to greet the group coming from Europe, where everybody else on my team went to Vienna, Austria to do the scans there. Yeah. So when we scored the European study called SIOPIN NBL1, HRNBL1, we found the exact same statistical cut point. Unbelievable. Totally different patient population, even a slightly different number of cycles, transplant regimen. We still found a cut point of 2 or less was the optimal cut point. So that was our validation set. And thus, Curie scores greater than 2 are associated with inferior survival in 2 totally independent studies. Well, how about this question? Is it better to have a Curie score 2 or less? Or how about just to have a large change in score, meaning go from 30 to 5? We looked at that too. So in red here, I've got the Curie score at diagnosis, the Curie score at end induction, and then what's the percent change in score? So if you went from, let's say, 20 to 10, that'd be a 50% change. And then we looked at the absolute Curie score. And so again, absolute score at the end of induction versus change in score, which matters? Well, here's the data right here from those same studies. Patients who had a Curie score greater than 2 and greater than a 50% reduction, that meant they started with 20, they went down to a score of 5. You know, it's greater than a 50% reduction, but their score is still over 2. Their 3-year EFS, does anybody know what EFS means? You know, sometimes we talk in doctor language. EFS stands for event-free survival. OS stands for overall survival. Overall survival means your child's alive. Event-free survival means that they've survived a certain time point, in this case 3 years, and they either A, haven't died, or haven't relapsed or progressed. The events would be, let's say, relapse or progression of disease, okay? So for those patients in this, you know, the Curie score was 5, they went from 20 to 5. The 3-year EFS was only 18.8%. Ugh. As you can imagine, those that the score went from 20 to 13, so the score was still over 2, but it was less than a 50% reduction, it was still poor. Then we said, well, let's raise the bar, 75%. So if your score was still over 2, but you had more than a 75% reduction, you can see that the 3-year EFS was 22.9% versus those that had less than a 75% reduction. What's the take-home point from this? The absolute Curie score at the end of induction therapy or post-induction matters more than just how much your child's Curie score has dropped from diagnosis. And for patients getting therapy similar to COG A3973, I'll stand by it because we've now validated in 2 studies, you want a score of 2 or less to go into transplant. In our center, and many centers will pull those patients off therapy and do that MIBG detour, or they may get chemoimmunotherapy with dinutuximab and chemotherapy to lower it if at the end of induction they have a high score. Well, I stand by this cartoon, this Dilbert cartoon. What does this all mean? You can read through it. This looks like my staff there. Is this being taped? Hopefully my staff will never read this cartoon. Be careful how we interpret the data, though. The majority of patients in COG A3973 did not receive dinutuximab. In fact, if you look back at that, what I showed you, everyone received a single transplant. Well, we're currently doing tandem transplants, and now virtually everybody's getting dinutuximab or immunotherapy. So when we stand up here and tell you we want a Curie score of 2 or less, well, that's based on single transplants when only about 20% of patients in the study we looked at even had the antibody. So what do we know about Curie scores in tandem transplants? My Ohio State friend, Carrie Strebe, just gave a talk at this at the ASCO, which was here in Chicago a month ago. And you're one of the first individuals to now see Curie scoring with tandem transplants. So it's the same cassette, induction, consolidation. There's 2 BMTs now. That's tandem transplant, radiation, and antibody. Again, scans are scored by the same group, Providence, Rhode Island. I love Providence, Rhode Island, by the way. Got great restaurants. Diagnosis and end induction. That's just my plug for Providence. So this is the distribution of Curie scores at the time of diagnosis, and then you'll see at the time of end induction. The bottom, across the bottom, it's hard to read, but you can see the numbers on the, it's called a histogram on the bars. If you had a score of 0 to, 1 to 3, 4 to 6, 7 to 9, things like that go across the axis down here. So roughly 25%, almost 30% of patients had a low Curie score at the time of diagnosis, meaning 6 or less. Approximately 60% of patients at the time of diagnosis have a Curie score that's 18 or above. In fact, the average Curie score for children in this country at the time of diagnosis is 20 out of a maximum score of 30. By the way, you should ask me, do kids that have a score of 30 do worse than kids that have a score of 20? No. Just get the score down, all right, to 2 or less, okay? How about, what have we seen at the end of induction chemo? How well does our induction chemo work? Well, our patients are generally responding well to our induction within the Children's Oncology Group. 60% of patients actually have a Curie score. This is on the tandem transplant trial called 0532. 60% of patients actually had a Curie score of 0 at the end of induction or pre-transplant. That means that they had no MIBG positive disease. You don't need to do scoring. The scan's just negative, okay, 0. And you can see how many patients persisted with really high scores at the end of induction therapy. So Carrie, Barry Shulkin, Meg Parisi, myself, we did the exact same thing. We scored scans of diagnosis and post-induction with tandem transplant and immunotherapy. And now you can see this. Again, you're some of the first folks seeing this data. Curie scores of diagnosis from the tandem transplant trial 0532. Patients with a Curie score at the time of diagnosis less than or equal to 12 actually did better than patients who had a Curie score over 12. Well, that's sobering because the average Curie score, remember what I said, was 20. Well, how should we interpret that data? I'd go back to the Dilbert cartoon cautiously, all right? Many patients with a Curie score over 12 at diagnosis actually did really well. The largest subset of patients at the time of diagnosis of neuroblastoma, with high-risk neuroblastoma, have stage M or stage 4 disease, and their tumor biology is MYC-N non-amplified. MYC-N is this gene that it's like a light switch that's turned on. Non-amplified means the light switch is off. So the largest population of patients, and many of you will have had children that fell into this, would have had stage M or stage 4 disease and MYC-N non-amplified. Those patients actually did well with a Curie score over 12. Oops, dang. Specifically, that subset had a 3-year event-free survival of 71%. It's really good. What that tells you is that a lot of the other subsets brought this curve down for patients who had a Curie score over 12. So does this mean that everybody should, should say, geez, what was my Curie score at diagnosis? It was 21. Dr. Yanik just showed me this curve. Ugh. No, for the vast majority of you that have, your children have stage M disease that's MIC-N non-amplified, no, that group did really well still. It was a lot of the other subsets that obviously brought the curve down. What do we find at the end of induction? Well, this is an easy one. Now it's not 2 or less. Now it's a Curie score of 0. We don't even have to do a score. It's whether your scan's still positive or is your scan negative at the end of induction therapy. Patients who have a Curie score of 0 at the end of induction therapy did better than patients who have a Curie score greater than 0. So the optimal cut point, as Carrie reported at ASCO, is a Curie score of 0. If this Curie score is greater than 0, the 3-year event-free survival is 46%. And if it's 0, the 3-year event-free survival is 73%. I guess I'll ask a question that you could ask me. I was thinking about, as I was listening to the questions asked of Ami, I'm thinking, what are people going to ask me? Well, here's one. Dr. Yanik, you just showed that anybody over 0 doesn't do as well as people who are 0. What if they're a 1 or a 2? Do they do better than somebody who's a 5 or a 6 or a 10 or a 20? The answer is yes. Okay? Meaning if your child is a 1 or a 2 at the end of induction, don't despair. The cut point means that this was the optimal cut point for seeing a disparate response. That if you had a Curie score of 0 versus anything above that, that was the greatest difference in survival. A Curie score of 1 or 2 at that time point, you still do pretty good, but the difference wasn't quite as great as the other group that was over, let's say, 2. But I would say that Curie scores that are 1 or 2 at the end of induction do better than Curie scores that are 10 or 20 at the end of induction therapy. And then this one. How many of you have been through antibody therapy with dinutuximab so far? So a good portion of the group. So we looked at it. We started to look at it, and we're about to go next week. On Monday night of next week, I'm flying out to validate this question. Flying out to Providence. Do Curie scores right part of dinutuximab therapy matter? This are the results from ANBL 0532. So we looked at patients who had a Curie score of 0 going into the immunotherapy or dinutuximab, and you can see their 3-year event-free survival is 71%, versus patients who had a Curie score greater than 0 going into dinutuximab. Again, those that were 1 or 2 didn't do poorly, they just didn't do as well as this group. Well, what does that mean? It needs validation. Look at the sample size. If you read the little thing in parentheses right here, it says Curie score greater than 0. It's only 25 patients. I'm not going to stand on a pulpit and say that everybody who has a Curie score over 0 going into dinutuximab should come off therapy. That's just based on 25 patients. Next week, several of us are meeting in Providence, Rhode Island, to look at a large subset of patients going into immunotherapy. I hope to be able to come back, let's say in a year, and say, all right, going into immunotherapy, here's what you want your Curie score to be. We hope to increase this 25 sample size dramatically. Okay. And then there's a study. This is my last 2 slides or so. This group, it was in Korea. They published a study recently. 150 patients all received a similar induction transplant immunotherapy as we give in the COG model. All patients underwent tandem transplant. This is really interesting. They looked at MIBG scans at the end of scheduled therapy. So you'd finished all 3 cassettes, and what was your MIBG scan at that point? So, and then they asked 2 questions. 5 years later from the end of your therapy, what were the chances that your disease would recur or progress? And what was your overall survival? If your scan was MIBG negative at the end of therapy, your chances for disease progression was 17%. If you're positive at the end of therapy, your chances for disease progression were 17%. Interesting. Overall survival. If your MIBG scan was negative at the end of therapy, it was actually slightly lower than if your scan was positive at the end of therapy. As a parent, you should be just dang confused right now. And thus, be careful of single center studies with smaller sample sizes. Everything needs validation. However, I'm sure Kate, Daniel, Ami, Brian, these are all physicians I'm looking out in the room, have all seen these patients who ended therapy and had 1 or 2 positive sites of disease. And the take-home point that these authors stated was this, that patients did well that had Curie scores of 2 or less at the end of therapy. I have a patient right now that finished therapy almost 6-7 years ago and still had a Curie score of 1 or 2, and I just kept treating. Then after a couple of years, I just stopped. It's now been 5 years later, and the patient's never progressed. That patient actually met this definition. Patients did well that had Curie scores of 2 or less at the end of therapy. Why would that be? Because MIBG scans are stupid. And since I'm being taped, you can quote me on this. Oh, good heavens. But MIBG scans pick up neuroblastoma. They'll pick up neuroblastoma, whether it's the really aggressive neuroblastoma. They'll pick up neuroblastoma that's really matured or differentiated, turned into a less aggressive form. And thus, a lot of these patients that did well at the end of therapy, they literally had what we call a ganglioneuroblastoma at the end of therapy, this really mature, well-developed neuroblastoma that was never going to progress, okay? That's why the scans are stupid. They can't tell you, is this a really aggressive tumor still there or the more mature tumor? So this is my conclusion slide. What do we really know? It's a cautionary summary. Curie scores in single transplants. I'll stand on this. You want a Curie score 2 or less at the end of induction therapy. It does matter. It's been validated in 2 studies. Curie scores in tandem transplants. All data were derived from ANBL 0532, that COG study. Keep in mind that study ended 10 years ago. It just takes us 5-10 years to analyze all the data. The sample size was small. It was 100 patients. A post-induction Curie score may be prognostic. We're going to validate that in the next high-risk study. Prior to antibody, this needs validation. I'm flying to Providence next week to get a much larger sample size. And post-therapy, keep in mind this one. Patients with low but positive Curie scores sometimes do well. Okay. All this needs validation. The current COG high-risk study, ANBL 1531, will examine many of the questions and provide many of the answers that I've shown on this slide. So I just want to thank the following folks here. Kate, obviously, I've mentioned her several times. My colleagues Barry, Meg Parisi, Carrie Strebe, Arlene, Fran Laurie, who runs the group in Providence where our scans are. Sandy Kessel works with her, the staff in Providence. But our patients. I don't know if you can read the quote at the bottom. I'll read it for you. We're all working so hard to be self-fulfilled, individually successful, and personally healthy, and we've forgotten the real purpose and path to health and healing is to make a joyful connection. I have to admit, that's why I'm here. That's why I do what I do. That's why I'll never retire. Because every day, I swear, I'm making more joyful connections with my colleagues, with all of you. In fact, the other day, a father gave me this note. He wrote it out and handed it to me. I'm going to read it to you again. Affliction produces endurance. Endurance, proven character. Proven character brings hope. And hope never fails. Actually, he told me it came from St. Paul in a letter to the Romans. I said, oh, I thought that was really intelligent. He said, no, St. Paul wrote it. But that quote, I decided to show it because it's a testimony to everybody here, to your children. The picture on the right is Kellen. Kellen was diagnosed at age 4 with neuroblastoma. He passed away this past year at age 14. Through 10, 11 years of therapy, he kept playing hockey at a fairly high level, being checked into the boards. The things we let him do, I sometimes shake my head. His parents, Jennifer and Corey, his whole family, they were special to us. And actually, I just want to end this talk by dedicating this talk to Kellen. I think many of you see on the schedule, I'm talking again in a couple hours on lessons I've learned from my patients. I'm going to be dedicating the next talk, not just to Kellen, but to all of you. Thank you.
Anyone have questions? Come up to the mic.
Good morning, doctor. My name's Amber. My daughter was treated at Children's Hospital Philadelphia. She was diagnosed at 4, received MIBG therapy at 5. She's now 10. So my question is, does the chance of the secondary cancer lessen or increase as they age?
That's a good question. It'll lessen, but I wouldn't say that you're out of the woods yet, okay? When I think of secondary cancers, what's your first name again? Amber. So Amber, when I think of secondary cancers, I kind of divide them into leukemias and then everything else. So the leukemia, you know, as MIBG therapy, to be honest with you, even the chemotherapy that your children have already had, as it runs through their system, they're beating up the blood cells. They're already at risk for leukemia, about a 2 to 3% rate. Leukemias typically occur within the first few years after therapy, not 10, 15, 20 years later, but typically within the first 1, 2, 3 years. Some of the other non-leukemia secondary cancers that we've seen, we've had 2 children develop osteogenic sarcoma, which is a form of bone cancer. And both children developed that osteogenic sarcoma approximately 8-10 years out from their MIBG therapy. I've never seen anything after that. Kate, have you seen anything?
No, thyroid cancer.
Thyroid cancer, true, yeah. Thyroid cancer, obviously, too, is a risk. I have not seen any cases of thyroid cancer. Kate, have you seen it? How late out did you see it?
I think about 8 years.
8 years? So your child's out 5 years, you said, Amber? So, you know, I'd feel good about things, but you just heard me now say that we had a couple children get bone cancer. Kate had a patient with thyroid cancer, you know, in that 8 to 10 year period. I haven't seen anything ever after that, though. Okay. Kate, you're not allowed to ask questions.
I'm Kate Mathia from San Francisco, and Greg, that was lovely. I wanted, a big problem for me has been discerning whether an MIBG positive spot is cancerous or is a matured tumor. Because, as you said, the MIBG can even be taken up in ganglioneuroma at times. And we see this, first of all, in the very young children with favorable cancers that mature, but sometimes their bone spots on MIBG do not go away for a couple of years, and we don't know whether to keep treating them. And then I've had patients with very high-risk disease after MIBG and transplant, whose MIBG, as you again mentioned, takes a while to go away. And I've been recommending FDG PET scans, which measure their glucose metabolism in a tumor, to see if these tumors are active. And it's reassuring if there is no FDG uptake in these spots, but I don't know if there's any evidence that that's a reliable test. And I wondered what your experience has been and what you think.
Yeah, and Kate's group has actually published on this, comparing MIBG, the sensitivity of MIBG scans and PET scans too. At our center, we've actually found this situation where it becomes Darwin's survival of the fittest, or a process of natural selection. And what the tumor is on the 3rd relapse may not be what it was at the time of diagnosis. The ability for a tumor to pick up MIBG and be seen depends in part on how many of those channels, you remember that one picture I showed at the beginning, that it has on the outside of it. Well, as these tumors go through their own cycle, you start to pick up clones that may have less channels. They may not pick up the MIBG at all. Okay, we had a patient not too long ago that was MIBG avid for a diagnosis, the first relapse or so, and then became negative, but the PET scan, like Kate said, picked it up perfectly well. And what happened is that that tumor lost those net norepinephrine channels to pick up the MIBG, but they could still pick up the PET because it's a totally different mechanism. And thus, Kate, to give you a roundabout answer to your question, we now use PET scans at our center in patients that were previously MIBG positive, and we still think there's strong suspicion there's disease because we find that the PET scan is a really high sensitivity for picking up disease too, especially in patients that were MIBG negative. So, yes, Brian. This is Brian Kushner from Sloan Kettering. I got these docs asking me questions. Come on.
Just, I was waiting for parents to ask. We have a huge experience with MIBG positive patients whose PET scans are negative. And we consider that evidence of no active disease.
Yeah.
And we have protocols, for example, that require somebody to be NED, have no evidence of, we actually say no evidence of active disease, because there's evidence of disease since the MIBG scans are abnormal. But the PET's negative, the bone marrows are negative, and we have a lot of, although sometimes actually the bone marrow shows ganglioneuroma, the benign form of neuroblastoma. So PET scans really can be very helpful in establishing disease status.
Are you doing it, PET scans, at the end of therapy then, if you're
Not
MIBG
routinely,
negative?
but if somebody has a positive MIBG scan, bone marrows are negative, and we have strong reason to believe that the MIBG is showing a benign form of neuroblastoma, meaning the ganglioneuroma, we'll do a PET scan.
I see.
And we have patients, high-risk patients. In fact, when I give a talk later today, I'll show a scan. And many patients come to us with, quote, refractory disease. And we say, this child probably does not have refractory disease.
Right.
Bone marrow's negative or shows ganglioneuroma. MIBG can have a Curie score very high. PET scan's negative, we stop therapy. So patients are being overtreated because of positive MIBG. So another thing I just want to mention is, you were going to say something?
Oh, no, it'd been interesting, that Korean study that I showed, if they had done PET scans too in those patients. Especially those patients that had those low Curie scores at the end of therapy that were still positive.
Yeah, so see those kind of patients, you might think about doing PET scans.
Right.
Yeah. Now the other thing is I have to say about MIBG therapy. We have a huge experience with MIBG therapy. And we actually published on it, that we carry out our MIBG treatments in a regular room. We do not have a lead light room. We showed that the amount of radiation beyond the room is safe. So it's done on a regular floor, regular room. Parents are in there right from the start. They don't have to be outside of the room for any hours. They're with the child the whole time. We actually even have our lead shield, lead line shield. It's actually transparent. It's not, it's not that high, but it's transparent. So families are together. And we've had patients come from elsewhere where they, didn't want to do an MIBG therapy because it seemed so difficult. And then they saw how we do it, they said, oh, fine. So just to point that out.
Our center, thanks, Brian, it's a great point too, because every center handles it a little differently, and I appreciate what you said.
Yeah.
I've been doing MIBG therapy now for 25 years, and we've actually had to move our site. Just life changes, we had to move to a different location where we do the therapy. Where we do it now is like Brian's center. We don't have a lead line room. They wouldn't build us one in our new hospital. So we just use the lead shields. And we use the top floor of the hospital so that the radiation goes out, corner room. But we're like your center now, Brian. We do not have a lead line room.
And
then we
just do it on the regular floor.
Yeah, so it's done on our regular floor.
Yeah.
We don't do it in our ICU. It's done on our regular floor. We have a great training session for nurses. We've actually worked out, Brian, all the data for what happens in a sentinel or emergency situation, how long ICU personnel can be in there. We use, like Brian does, we use transparent shields. So these are shields you can actually see through. It's like a door that you can see right through. I mentioned that our patients can't be in the room for the first several hours after therapy. How far away are they? Well, it can be from here to the chair, I guess. But you can see right through the shields. So, okay.
Yeah. Oh, maybe one more question.
Let me also just say how much I appreciate Dr. Mattheis and your work in terms of advancing the use of MIBG imaging, the Curie score, and the treatment. So it really, I can think of many patients who I would say are cured because of the MIBG treatment that they were able to get thanks to you folks.
Right.
Thanks,
Okay.
Brian.
Maybe two more questions because we're still running late, but go ahead.
My son was diagnosed and first treated with high-risk neuroblastoma in 2018, and he still had a Curie score of 4 at the end of induction, and then he went and did one of the detours with 3 rounds of dinutuximab IT to bringing him down to 0. You also mentioned doing these detours. Is that, but it's still not 0 at the end of induction. Do you think you're actually affecting the long-term survival by doing that?
Yeah, so Meredith is your name, right?
Meredith Goldsmith, I'm from San Francisco.
Yeah, I met Meredith at breakfast. No, it's a good question. If you do these detours, so you got at the end of induction therapy, you have a Curie score of 4 or 5. We typically will just try to get that Curie score down to 0, 1, or 2, and then we'll go back to transplant. In some cases, we've never even gone back to transplant. We've had a number of patients at our center that they responded so well to immunotherapy, they went from a Curie score of 4 or 5 at the end of induction to 0 after a couple cycles of the immunotherapy. We just kept the chemo immunotherapy going with the dinutuximab and the chemo, the irinotecan and temozolomide. So, in fact, in some ways, it's not only a parallel path. They never come back to transplant in many of those patients. And go back to also what I said, Meredith, is that the patients who have a score of, so let's say your child's score is 3 or 4, do they do significantly, is it a total fall off a cliff once you hit a score over 2? No, it's not. You know, it's a graded decline. So we've had a lot of patients go into transplant with scores of 3 or 4 at our center and still do well, actually. So, okay. But I get nervous when the score gets over 3 or 4, at least when we were doing single transplants. But we've done that with patients too. At our center now, if you have a Curie score 3, 4, 5 or so, we likely will do immunotherapy with dinutuximab and chemo or MIBG therapy to get that score down. If they have a rapid response, we may just stay on the immunotherapy. If they have a graded response, we may then go to transplant. So each patient is taken individually.
Okay, one more question.
Yes, Anna.
You are
We're going
getting
to
all
we're going to take a break too after this, so if you want to discuss. Okay.
I just wanted to follow up on that last question, because we recently published a paper, because we had the exact same question. Does this quote unquote bridge therapy or chemotherapy plus antibody that we sometimes give in between induction and consolidation, does it help at all? Does it do anything? Of course, this is looking backwards. It's retrospective data. It's not looking at it forwards, but a few key points that came out of there is we grouped patients. One, these were all patients who did not have a complete response at the end of induction. So group 1 were patients who went straight on to transplant. Group 2 were patients who got what we call this bridge therapy and moved on to transplant. And group 3 was a small group of patients who got this, after induction therapy, but, for one reason or another did not move on to transplant. And I'm sorry, group 2 was the bridge and then moved on to transplant. So anyways, a few key points that came out of, again, retrospective study was, of course, this group 2 patient that got bridge therapy were a little bit biased because they had a worse end of induction response. But what we did see was that their survival outcomes were now similar to group 1 that went straight on. So maybe there's some benefit from getting bridge is, one takeaway. And the second takeaway were when we compared patients who had what we called stable disease in the areas of metastatic disease, when we compared the patients who went straight to transplant versus those who got bridge, we saw that those who got bridge therapy did better than those who did not in the certain, metastatic stable disease. So anyways, that, at least meant to us that perhaps there was some benefit to give bridge for certain groups of patients. This, of course, needs to be looked at prospectively, which I think we will have the opportunity to do in the upcoming clinical trial, but it gave us some semblance that perhaps there are certain groups that might benefit from getting sort of that in-between therapy.
The upcoming clinical trial, thanks, Ami. The upcoming clinical trial, the next high-risk trial will bring that, quote, bridging therapy up front. So now patients will be getting immunotherapy during induction. Okay.
Okay. We're going to take a few-minute break now, and we'll get back in about 10, 15 minutes. There's some snacks and stuff up against the wall there.